Dr. Seniors and then my colleagues, very good afternoon. Today I'm going to talk about cataract surgery in special situations as invited by Dr. Lili Rajbansi. Thank you very much for the invitation. I don't talk much on cataract usually in the meetings, but I think this is my second time. I'm so lucky to talk again for the cataract with Professor Sanjay Singh, who is one of the pioneers in cataract surgery in Nepal actually. He started, I think, the first cataract phaco surgery in Nepal. So it's honor for me to again talk. Initially, I think we did one instruction course on phaco in SAR, and this is the second time. And I think this is the second time I'm talking about the cataract in the meeting. I usually talk about oculoplasty in most of my places. So now I started private. I work in a private hospital called Global Eye Hospital. We have 3 branches. We started in 2013 and now 2014 we have 3 branches fully functioning for cataract surgery. So when Lili invited me to talk on cataract surgery, I thought what to talk. And then I realized before joining ophthalmology as a field in 2003, I thought all the cataract are same. What cataract surgeon are doing? And now she gave me the topic that I have to talk on special situations. Then, as I joined ophthalmology field, then I realized not all the cataract are same. Because there are traumatic cataracts, some diabetic cataracts, after silicone, FAB cataract, or whatever, there are different cataracts. Now, with the experience of like almost 23, 24 years, I realized that not only cataract is different, now the patients are different, the capsule is different, the cortex is different, the nucleus is different, and the posterior capsule and anterior capsule is also different. Even the anterior chambers are not same in all patients. So the fluidity has to be, every patient has to be tailored now. So it's not cataract surgery for all. So by the time when resident learn to do a cataract surgery, basic cataract surgery, they think that now I know everything. But later on we realize, no, I don't know anything. So I think I'm in that phase now, but whatever the case, I have to talk. So I'm going to talk on, today my objective would be talking on 3 special situations. I'll just talk about 3 special situations. One is posterior polar cataract. The second one is subluxative cataract, and then third one would be a small pupil cataract surgery. And then I'll give 3 tips in each of the topic. So posterior polar, going into the topic, posterior polar cataract has the high chance of posterior capsular rupture, vitreous loss, loss of eye back support and nucleus drop, and eye drop that can happen. The main reason behind this is there's film adhesion of posterior capsule to the cataract. The main problem is there. So we have to identify the main problem is not the vitreous loss. The capsule is adhering to the cataract. We have to realize that. And this is the one video to show how we perform posterior polar cataract. I think that every posterior polar cataract is different. Not all the posterior polar cataract are same. I cannot assure you that this video shows good cataract surgery. It doesn't mean that I can do good in every case. Because every posterior polar has different variety, different combinations, and different technique. Now here we are trying to show more hydrodelineation. Hydrodissection is sometimes important, but hydrodelineation is more important to preserve the posterior capsule tearing. Don't do hydrodissection liberally as in other cases, otherwise your nucleus will drop down suddenly without you knowing why that fell down, So, and even the nucleus, if it is immature nucleus like this, not hard nucleus, then you can manipulate and bring it into the anterior chamber and then do the phacoemulsification. I don't advocate doing phaco inside the back in this kind of patients because the chance of drop is high. And then even in the cortical removal, the tangential drawing of the cortex from the top to down. We don't pull the cortex from down to up. Always from top to down and then tangential. I left behind one plug there, which was difficult to clean. Actually, you have to make sure that there is no any cortex on that capsular plaque. We have seen that I've done a capsular polishing at the end of the surgery, which will ensure that there is no any cortical matter there. Otherwise, that will obscure the vision. Otherwise, this plaque would not obscure the vision. If needed, this can be done later safely. So what are the learning tips in the posterior polar cataract? The capsular axis, whether to make it big or small. People will say that try to make it smaller so that you can freeze up the capsule and then put a sulcus lens. What I prefer larger if the patient has nuclear sclerosis along with posterior polar cataract. Because you don't have to manipulate much lens inside the bag. If you make a big capsule, you can always prolapse that nuclear sclerosis cataract and then do the surgery safely. I think in this case we have done like 5 to 6 millimeter of capsulotomy. So capsular opening, in contrast to people saying that make a smaller capsulotomy on posterior polar, no, make it big. And then hydrodelineation always in compared to hydrodissection. Prefer hydrodelineation on these patients. And of course, nuclear manipulation, as I said, not possible in all the cases. If the patient has immature cataract, you can always pop it out from the bag and then do the phacoemulsification as shown on this video. But in case of hard nucleus, and then if you still see posterior polar cataract, make a large capsulotomy and then bring the intact into the interchamber and do the phacoemulsification. So next is subluxated cataract. Capsular axis is very difficult to start in subluxated cataracts. And again, nucleus delivery, you cannot pop out the nucleus, or you cannot easily move the nucleus. Even the nucleus drop is high, and effective living patient effective chance is high. Cortical wash is again difficult, especially on the place where there is subluxation. It's very difficult to do the cortical wash. If you keep on trying doing the cortical wash, you'll pull all the journals from there, and then patient will be without journals. So this is another difficult step. Eye replacement is also again difficult. The main reason here is unstable capsular support. We have to address that. As you see that this is the anatomy of the lens and the journals. I'm trying to show you one patient who had a surgery with subluxation. You can see that there is almost 50% subluxated. Lens was into the antechamber on the inferior side. The lung support was in the superior side, and we did a SICS because we anticipated some complications on this patient. And then there was also synovitis was done, and then capsulotomy, big capsulotomy again. Always I emphasize for the big capsulotomy. Initially I thought that I should make it small, but now I think all cataracts should have a big capsulotomy. So now when you prolapse this nucleus, this immature cataract, because it is traumatic. So immature cataract, you have to prolapse from the strong support area. You should not rotate from the weaker journal area. Otherwise, if you rotate that way, you destroy more journals. And then we are going to put a CTR on this patient. Now I put a another CT segment as well apart from this. But this was a CTR, 13 millimeter diameter CTR for the adults. And then, of course, the eye went into the bag. And that's how we do our subluxated cataract. And in subluxated cataract, as I said, the capsulotomy has to be bigger. Why? Because you don't want to press more into the journals. If you make a smaller axis, you try to rotate the nucleus, you do hydrodissection, everything increases pressure on the journals, and that weakens the journals more and more. If you make a large capsular axis, the entire nucleus can easily pop it out without any journalar further stress. And nucleus and cortical matter manipulation, again, as I said, you have to manipulate from the area where the journals are strong. Even in this case, if you start the rhexis, the first step of rhexis should be started from the strongest journals, not from the weak journals. If you start, suppose I have an inferior journular dehiscence, if I start a journal, the rhexis from inferior part, the journal will get more damage. It's very difficult, it won't come. But if you start from the strong part, it will be easy. And similarly, cortex manipulation has to be very gentle here. As I said, in this particular case, I think jonular variations, if you pull the cortex, as I said, from top to bottom, on the part where the jonules are weak, we'll pull the entire jonules out. If there is a jonular weakness, and if you pull from here up to down, you pull everything out. But you know that posteriorly into the anterior vitreous face, down there is adjustment, then you should start pulling it from down, because this is the strong part. This is jonule is weak here. So you start the cortex from down. It's opposite. You never do this in normal cases. But in case of jonular variations, I think this is one trick that can help you to remove cortex. CTR placement. CTR placement is not always easy. It goes sometimes into the vitreous, sometimes it goes into the sulcus. It won't inflate your back. And you can easily notice when it inflates the back, you can notice that the CTR is in the right place. So to make sure that the trailing active has to be go inside the back first. You have to put more viscoelastic before you put the CTR. So more viscoelastic, deep down into the inside the back, the trailing, and then the next part of the active has to be, as I showed here in this video, so you can see that it has to be down inside the bag and leave it inside the bag. You can see that manipulation here. I go inside and then I just leave it inside, deep inside, because most of the time we are worried. We live in the anterior chamber, I mean more towards anterior chamber or into the sulcus. So if you go deep inside, it will definitely fall inside the bag. The last topic here is cataract surgery in small people. So the problem here is small capsulotomy, nucleus delivery is always difficult, phacoemulsification again difficult part, iris trauma, cortical wash is almost difficult in small people, and IOL positioning and placement are not sure where it is. Sometimes it is one in sulcus, one in back, you don't know where the lens positioning is. So the main problem is inadequate surgical view. The whole problem with viewing light is because of inadequate surgical view. I'll show you two cases. One, it goes very smoothly, and the next is the one that I want to show you. This is a patient with uveitic cataract, whereas also there is fibrosis inferiorly. So we release and cut the fibrosis here. We're doing a synecholysis. Synecholysis is very important on these small people, because if you don't do synecholysis, and if they synechia, and then if you do the rexis, you'll definitely in a big trouble. You'll drop the nucleus if you do that. If there is synechia, so you have to release that synechia. So I did a rexis here, a small rexis. Yeah, I was overconfident to do this case with a small rexis, and then we did everything went all right actually in this case. We did a phacoemulsification and we implanted IOL without any problem actually. This was a very good case, but this is not true all the time in the small people. So I'll show you another case with diabetic patient, immense cataract, diabetic patient and mid-dilated people. So I was doing rexis here, and rexis went all right. Then I always make a side port to remove the subincisional cortex. Here I did a hydro, and then everything was fine. Actually, people got a little smaller, and then I started phaco because this rexis was smaller. So you can see that as I go there, you saw that there was a torn posterior capsule came inside the phaco tip. Now I immediately changed my mind. I should do exercises now. Previously we talked about bread and butter. You should have knowledge of both bread and butter, because that time it can be helpful. Now I removed now the immature nucleus. Actually I should have still done capsular, iris stretching here before removing the nucleus. So I can remove that cortical part here, because of the small nucleus. See that vitreous is coming. I'm trying to remove and nothing is coming. So now I decided I should not do more. I decided now I should have done this before actually. I later on realized that I should do it now. And I actually put this is a capsular, the pupillary stretch iris hook, and then now I don't use this again. I use my ring instead of this. And then now the cortex C, very easy to remove. You can see all the cortex, you can see the capsule, everything is visible in front of you, and it's more easier to complete your case. So we remove the cortex. And I did also anti-vitrectomy was done in this patient. I did anti-vitrectomy on this patient and removed some cortical part. And finally, I gave a lens into the sulcus on this patient. So the main learning point this is the end of the surgery, I think. This is how the patient, I gave a myocol on the patient, and then the pupil got constricted. And it looked almost the normal, Nobody knew what I did, at the end of the surgery. But I should have done the iris hook before I started my case. So cataract in small pupil, always preparedness should be there. When you have a small pupil, because that may be a case of glaucoma. As Dr. Bhaskar said, severe exfoliation can be a case when there is no pupil dilatation. That can be a uveitic cataract, that can be a posterior polar cataract, which I have never seen. And then I think you should prepare for everything now. You should get ready with your vitrectomy set and everything, like iris hook and everything. Pupil stretching is utmost important in small pupil. So don't underestimate the pupil, small pupil. And IL and cortical glass is very important here, and then you should be very careful to remove these things. I think that was the end of my topic.